5, 4, 3, 2, 1, live stuff.
Good morning, everyone, to all our participants and viewers, as well as the panelists and the moderators on this morning's Isg Masterclass. As you all know, today we'll be having a panel discussion on the multimodality management of carcinoma of the pancreas. This morning, as you will have noticed, we are missing Dr. Govind Makharia on the panel as he is preoccupied with some urgent personal commitments. Well, we are now completing about 5 months of these ISG masterclasses, which we began sometime in mid-April, and this is the 27th or the 28th session. And for the last, this is the third session that we are having as part of the ISG GI Oncology series, where we are discussing, I think the fourth one, that we are discussing about important in an area of gastroenterology where a lot is happening. Things are very rapidly moving, but it is generally kind of off the beaten track for most gastroenterologists, and you don't find a lot of attention to GI oncology topics, except when we talk of palliation and similar interventions. Keeping this mind, in mind, we thought it would be a good idea to go through our current state of management of these common cancers. Today, we will be talking about pancreatic cancer, which all of you would agree is one of the most difficult cancers that gastroenterologists and GI oncologists have to deal with. Not only because of its setting can be quite diverse, apart from a genetic background, we also know that in chronic pancreatitis, in calcific pancreatitis, we may have cancer coming in. It is one of those tumors that is difficult to detect early, not only because it is in a part of the body that is difficult to access and image, but also because it is very aggressive in its spread. Many of these tumors are chemo-resistant, radio-resistant, so they offer a challenge to the clinician who has to manage them. And often radical and quite major surgical interventions are needed if cure is to be attempted, while endoscopists, radiologists have to chip in with palliative interventions. Now, to take us through this whole gamut of management of carcinoma pancreas, we have assembled a star panel of experts who will be moderated, and in fact, your driver and conductor for this journey will be Dr. G.N. Ramesh. You all know Dr. Ramesh. He is the senior gastroenterologist and head of the Department of Gastroenterology at the Aster Medicity in Kochi. He's also a former president of the Society of Gastrointestinal Endoscopy in India. We also have Dr. Shailesh Srikhande, professor of surgery and head of GI and HPB surgical services at the Tata Memorial Hospital in Mumbai. One of the most experienced surgeons dealing with this difficult tumor in India. For the nuances of diagnosis and interventions, the role of interventional radiology for carcinoma pancreas, we have Dr. Raju Sharma, professor of radiology at the All India Institute of Medical Sciences and one of the leading radiology experts in the country. Dr. Akash Jha is a medical oncologist at the National Cancer Institute of AIMS at Jhajjar in Haryana. And we hope to get insights into the new developments and promises on the horizon for the oncologic management of carcinoma pancreas. And finally, Professor Sudipto Dhar Chowdhury, professor of gastroenterology at the Christian Medical College, Vellore, will chip in from the beginning to the end at places to talk about the role of the gastroenterologist, who's often the first person on the scene when the diagnosis is made, and who's often the last to support the patient when palliation and re-interventions for further palliation are required. With these few words, let us begin, and I hand over the baton to Dr. G.N. Ramesh to set the ball rolling for this afternoon.
Thank you very much, Professor Vivek. I'll start sharing my screen, and that is where I start. A warm, very, very warm good morning to you all. If you could see my screen.
Yes, we can see your screen, Jian. Could
Okay.
go to the full screen mode, yeah.
Right. So basically, the webinar is on carcinoma of the pancreas, a multidisciplinary approach. And I have a very rich panel with me. As we all realize that approach and management of carcinoma of the pancreas has to be a team-based approach, which involves a gastroenterologist, surgeon, radiologist, oncologist, and maybe some more also. We all realize that PDAC, or pancreatic ductal adenocarcinoma, as it is known, is a silent killer. Surgical resection is potentially curative. Unfortunately, even at this, I may stand corrected, 15 to 20% are resectable. And even after complete resection, the prognosis does not seem to be too good, with a 5-year survival after surgery being 25 to 30% going by literature if node negative or 10% if node positive. Improved imaging techniques have resulted in better detection, better staging, and palliative therapy and efforts to prolong good quality life are still the important goals. Our focus today is going to be set on answering a few questions. What are the best set of investigations? What is resectable? What is non-resectable? What is borderline resectable? Is tissue diagnosis always required, and how best to do it? The surgical results, the choice of surgery, and modifications thereof. The role of neoadjuvant and adjuvant therapy, and of course, we end up with the algorithms. Let me also be very clear about the fact that we are not going to be discussing NETs or the cystic lesions of the pancreas. We start off with diagnosis, and as Professor Vivek said, the starting point is usually the gastroenterologist. And most often, this patient presents as a mass lesion in the head of the pancreas. Suspicion of malignancy is there. Dr. Sudipto, what questions do you ask yourself when you're faced with this clinical situation?
Thank you, Dr. For the wonderful introduction. Just to take you briefly what Dr. Ramesh was alluding to, that when you talk of mass lesions in the pancreas, the one thing that we have to always look out for is a pancreatic adenocarcinoma. But there are a number of mimics which can confuse the picture. And these include an inflammatory mass in the setting of an underlying chronic pancreatitis, which is more often in our scenario in India. Then, of course, you have the mass-forming lesions in autoimmune pancreatitis and the groove pancreatitis, or the pancreatitis involving the pancreaticoduodenal groove. Now, if you look at the incidence of benign lesions that we have found out during Whipple surgery over a period of time between 1990s, 2000 and 2014, there's a significant number of lesions are still get operated with for benign lesions. Having said this, so if you ask us as a gastroenterologist when to suspect malignancy, one of the things that has been taught to us from the time we were medical students, from the DM students, was that if you have a patient with new onset diabetes mellitus in a middle-aged person, please suspect pancreatic cancer. In addition to that, when there is a mass in the pancreas, the other things that which point towards malignancy could include an older age of the individual, a worsening abdominal pain, presence of jaundice or gastric outlet obstruction, and significant loss of weight. And of course, if you have an elevated CA99, it definitely is a pointer towards a possible malignant lesion.
Thank you, Sudipto. It's always said that we usually start with an ultrasound, but we're not going to discuss much about ultrasound because we take it for granted that each of these patients has gone through an ultrasound. But I'd like to ask our radiologist on the panel, and I know that he's a leader in radiology in the country. Of all the imaging modalities, two imaging modalities that come to our mind are CT or MRI. The question is CT or MRI, or do they have a separate role by themselves? And what is the role for contrast enhancement? And what is the information that as a radiologist, you would expect your radiologist to provide to the clinician? Over to you, Dr. Raju.
Thank you, Dr. Ramesh. Yes, as you rightly pointed out, ultrasound is essentially used as a screening modality just to detect the presence of a mass and the presence of biliary obstruction. Following that, I think MDCT is really where the money lies as far as imaging the pancreas is concerned. That is the workhorse of pancreatic imaging, especially in the context of PDAC. It is useful both for detection, for trying to characterize the lesion, for distinguishing it from inflammatory pathologies that Sudipto alluded to earlier, like mass-forming chronic pancreatitis or mass-forming AIP or the paraduodenal pancreatitis. So it helps you in detection, in characterization, and more importantly, in staging the disease by a detailed analysis of the tumor vessel contact, which is what the surgeon is interested in before he plans surgery. Having said that, there is a problem-solving role for MR. It's not the primary modality, but we use it when the CT findings are equivocal. It is very useful for detection of isodense masses. We know that about 10% of pancreatic cancers can be isodense on CT, and they may not deform the contour of the pancreas, but just cause a ductal obstruction. For those kind of lesions, MR is very useful, and MRCP comes in handy. It's also very good for small liver lesions for detecting distant spread of disease from a pancreatic cancer and for peritoneal metastatic disease. There is an important sign that we use to distinguish between inflammatory masses and neoplastic masses, and that is the duct penetration sign. The pancreatic duct tends to penetrate through an inflammatory mass, whereas it tends to get cut off by a adenocarcinoma, and that is what is very easy to delineate using an MRCP. So I would say the primary technique is a good contrast-enhanced multi-phase CT and problem-solving role for a contrast-enhanced MR. As far as what information we give to the clinician, of course, the presence of a pancreatic mass, try to characterize it, whether it's inflammatory or neoplastic in nature. If it is neoplastic, is it a ductal adenocarcinoma or is it a neuroendocrine tumor? Because they have a very different appearance on imaging. We then, in an MDT setting, sitting with the surgeon, try and stage the disease and assess the surgical resectability of that lesion. Next. The typical imaging appearance of a pancreatic ductal cancer is that it's a hypovascular tumor. It's a desmoplastic tumor. So early in the course of disease, it tends to produce ductal obstruction, both of the common bile duct when it's located in the head of the pancreas and of the main pancreatic duct, producing the typical double duct sign, which I'll show you in a little while. It is an infiltrative tumor, and therefore it infiltrates the surrounding mesenteric vessels, the SMA, the SMV, the celiac axis, the aorta, and the IVC. As we know, the commonest location of this tumor is in the head of the pancreas, and therefore it produces biliary obstruction very early in the course of the disease. So important to remember that this is a hypovascular tumor, so on CT will be seen as a hypo-enhancing lesion, in total contrast to the neuroendocrine tumors, which appear as hyper-enhancing tumors because of their hypervascularity. If I could go to the next slide. So typically we do a biphasic CT. We want a pancreatic phase and a portal venous phase. And for the purpose of postgraduates, the pancreatic phase is acquired at 45 seconds from the beginning of injection, and the portal venous phase at about 70 seconds from the beginning of injection. Use of contrast is absolutely mandatory. There's no point doing a non-contrast CT at all. If for any reason you cannot inject iodinated contrast in a CT because of a previous contrast reaction or something like that, it's better to do an MR. A non-contrast MR is way superior to a non-contrast CT. I would say a non-contrast CT is absolutely useless and should not be done. If for any reason contrast cannot be given because of deranged renal parameters or because of previous history of allergies, then you would want to do a non-contrast MR. Next, please. So these are some typical appearances of a pancreatic ductal adenocarcinoma. And if my cursor is visible, this is the lesion that I would like to show. It's not really deforming the contour of the pancreas, but notice that it is causing an abrupt cutoff of the main pancreatic duct in the body and tail of pancreas, which is dilated. There is atrophy of the distal body and tail of pancreas, and there is this subtle lesion sitting in the neck of the pancreas. If you do a curved multiplanar reconstruction, you can, for your surgeon, delineate the entire pancreatic duct in one image, as has been done in this particular image. This is an MRCP image showing you a double duct sign. So this double duct sign is essentially a ductal obstruction of the common bile duct and the main pancreatic duct in close vicinity. And this also points to a PDAC located in the head of the pancreas. If I can please go to the next slide. So this is again the typical hypovascular appearance of a tumor located in the uncinate process of the pancreas behind the SMA and the SMV. And this is the post-contrast MR image showing you the same tumor producing a double duct sign. So the role of MR is essentially in very small lesions which do not deform the contour of the pancreas. If you go by the literature, as per the NCCN guidelines, both CT and MR are equally accurate in trying to stage the disease. However, most radiologists and surgeons are more comfortable looking at a good MD-CT for this purpose rather than an MR, and therefore we reserve MR for the problem-solving role and in those situations where CT contrast cannot be given. In the Western world, where they screen some high-risk groups for PDAC, like patients with IPMN or with Peutz-Jeghers, they use MR for the purpose of screening in the interest of radiation protection. Next slide. So this is the typical MR appearance. These are T2 weighted axial images showing you a hyper-intense lesion, a T2 bright lesion located in the head of the pancreas. These are some diffusion weighted images. We find these very useful in the context of pancreatic cancer. So this is a trace image from a diffusion weighted sequence. And what you see here is a very bright lesion, which shows you restriction or dark signal on the ADC map. This is the typical appearance of a pancreatic ductal cancer. I can go to the next slide, please. And these are again some more contrast-enhanced images of a hypovascular tumor sitting in the region of the uncinate process behind the SMA and the SMV. Next, please. And that's the typical example of a double duct sign. You can see the dilated common bile duct in the suprapancreatic location and an abrupt cutoff of a dilated main pancreatic duct as they approach the head of the pancreas. And this double duct sign, because of a obstruction to the two ducts in close vicinity, is produced by a PDAC located in the head of the pancreas. Next, please. As I referred to, MR is very useful for picking up lesions. Small sub-centimetric lesions in the liver are difficult to characterize on CT. And when you want to characterize them better, then MR is the way to go. And a diffusion-weighted image is very useful in that context. When you see these small lesions in the liver producing restricted diffusion, you know you're likely dealing with liver metastatic disease. Next, please. So as far as the information given to the surgeon, we've all switched to using a structured reporting template. Many articles published earlier have shown that a structured reporting template is more useful for the surgeon. They find it easier to extract information from those. Next slide. And these there are templates available, and the useful template which we tend to follow is the NCCN template provided in 2019, which gives a detailed description of the tumor, a very detailed analysis of the tumor in the context of the SMA, whether the angle of contact is less than 180 or more than 180, the angle of contact with the vein. Next, please. And we also then define the presence of liver lesions, ascites, the presence of lymph nodes, and finally give out an impression of whether the tumor is resectable, unresectable, locally advanced, or has distant metastatic disease. Thank you.
Thank you very much, Dr. Raju. That was quite exhaustive and very, very informative. The important thing, of course, is that contrast enhanced CT done with a pancreatic, as per pancreatic protocol, is probably the most important. And if for some reason contrast cannot be given, MR would be the next best choice. Now, we now shift our focus to endoscopic ultrasound, and that seems to be the in thing. And I'd like to ask our gastroenterologist, Dr. Sudipta, how has EUS influenced the management of Ca pancreas? Whatever Dr. Raju mentioned about CT, MRI, what additional information does EUS give over and above these investigations? Over to you, Sudipta.
Thank you, Dr. Ramesh. So as what Dr. Raju was alluding to, on overall, if you look at the comparable sensitivity and specificity of all these three modalities, MRI, CT scan, and EUS, they are virtually all comparable, except for that of SPECT-CT. Sensitivity of MRI, CT scan, and EUS is comparable. We move to the next slide, please. Now, but what do we do in a situation where this multi-detector CT leaves behind an indeterminate lesion and you have a high suspicion for a pancreatic cancer? Now, this is a meta-analysis of 206 patients. There are 4 studies, 206 patients. The pancreatic masses were detected in about 144 patients, of which 40% were turned out to be neoplastic. And the sensitivity of doing an EUS after an indeterminate multi-detector CT was very high, around 85%. However, the specificity was low. So there is a role for doing EUS when the lesion is indeterminate on MDCT. Move to the next slide. And most of the lesions, as was identified in the previous study, also showed that most of the lesions were actually less than 2 centimeters. And this is our target area of interest, because these are the lesions which would benefit best from a surgical intervention done very early on. Next slide, please. In addition to the indeterminate lesions, the other things which EUS gives a very good information is the vessel involvement, particularly venous invasion. The 3 signs that we look for in venous invasions are whether there are peripancreatic venous collaterals in the area of the mass that obliterates the normal anatomic location, whether there's a tumor within the vessel lumen, or as in this particular image, there's an abnormal vessel contour with the loss of vessel parenchymal sonographic interface. Now, all of these are good signs to say that there is a vessel invasion in this case, involvement. Now, if you look at the overall sensitivity of this, the sensitivity is around 72% for EUS and much higher than that of CT scan. If you 9 studies where there was a head-to-head comparison between EUS and CT scan, the sensitivity of EUS to detect venous invasion was definitely higher than that of CT scan. As for, however, the specificities were similar. The area under the curve was higher for EUS as compared to that of CT scan. So, but as regards venous, that's regards venous invasion. But what about arterial invasion? The surgeons are nowadays not that concerned about venous invasion. They are more interested to know about the arterial invasion of a lesion. And if you look at the arterial invasion, now there are 2 recent studies which looked at this, where the EUS could predict the presence of arterial invasion. And they compared it against post-operative findings. And the 2 things that stood out was if there's a loss of vessel color integrity, clear invasion, or a contact with loss of hyperechoic vessel wall. These are very good sensitive criteria to identify arterial invasion. And in the first study, the sensitivity to detect arterial invasion was to the tune of 70%, specificity of 84%. Similarly, for the other study in 2019, the sensitivity was pretty high, 83%. And if you compare this particular criteria, that is contact with loss of hyperechoic vessel wall, then and in the postoperative findings, with contact without loss of hyperechoic vessel wall, then there is a difference between the tumor and the vessel location by about 1,000 micrometers. Now, whether this is very useful information when the surgeon is trying to obtain an R0 resection. Moving ahead. So, other studies have looked at whether there's an incremental benefit of adding EUS to the already available information on CT and MRI. Now, this is, of course, this is a meta-analysis published in 2017, but included data from 1992 onwards to 2007. So, obviously, the generations of CT scan have had a huge change. The quality of CT scan images that we get have a significant change. So probably the data may not be as relevant as it was at that point of time. But having said this, there is a benefit that when you add EUS to lesions which were deemed resectable at CT or MRI, then at least 19% of them were found to be unresectable when you did that EUS. And if you move on to the next question. Yeah. Sorry, no. Sure, please go ahead.
Okay. So thank you, Sudeep. So we've gone through the gamut of investigative modalities, the imaging techniques, which will give us a lot of information. Now we are left with making a decision as to what is to be done. And I understand that central to this decision making is the staging. And staging is basically done best by the radiologist in association with the EUS findings, whatever it is. So may I request Dr. Raju to tell us, how do we stage pancreatic cancer? There are so many systems. You go into the literature. Which is the staging which is most relevant and useful?
So firstly, for the purpose of staging, you need a good quality CT and MRT setting in a high volume center. I think that is where an appropriate stage can be assigned to a lesion. And it's not just the surgical resectability that we are talking about, but trying to predict an R0 resection or trying to predict oncological curability. As you mentioned, there are different systems. There is the TNM staging system given by the AJCC, which is more useful for prognostication. There is an ASCO staging system, a staging system from the MD Anderson group, and the NCCN staging. In our institution, and I think most oncology institutions, it is the NCCN staging that is more universally followed in trying to classify the disease into resectable, borderline resectable, and locally advanced or unresectable disease. You could go to the next slide. So basically, you need a high-quality pancreatic protocol CT, not more than 4 weeks before surgery. If only a standard single-phase CT is available, it's a better idea to repeat that CT, do a good quality CT, and sit on a workstation with your surgeon and evaluate multiplanar reconstructions as well as MIPs or maximum intensity projections, and then you stage the disease appropriately. Next, please. So the TNM staging is more useful for prognostication and is based on the size. The T stage is based on the size of the tumor, the N stage on the number of lymph nodes. But this is not something that helps you decide the management for that particular patient. That is best done using the NCCN staging system. Next, please. Next. So this is really where this is the more important slide for the staging purpose. The resectable disease is when there is no arterial tumor contact. And on the venous side, either there is no contact or there is a contact of less than 180 degrees, which means it's only abutting the vein but not invading the vein. Borderline resectable is the category where the arterial contact is there but is less than 180 degrees. On the venous side, the contact can be greater than 180 degrees, but you should be able to show to a surgeon that there is a reconstructible vein both above and below the site of involvement. Unresectable disease, on the other hand, is when the arterial the contact with the SMA or the celiac axis is greater than 180 degrees. And on the venous side, you do not have a reconstructible vein available. The vein is occluded by tumor or by a thrombus, and there is no possibility of a safe resection and reconstruction for the surgeon. Next, please. The accuracy of staging is in the range of about 90%. Imaging does a much better job of deciding unresectable tumors than it does as far as resectability is concerned. And many studies have shown that when imaging says that the tumor is resectable, only about 70 to 80% of those tumors are actually found to be resectable at surgery. There is some role for PET-CT, although it is not something that is routinely done. And it has been advocated in patients who are at high risk, those with very large tumors, those with large lymph nodes, or in borderline resectable tumors, to pick up distant metastatic disease, and which would then preclude surgery. Next, please.
Well, thank you. This is about the conventional imaging with respect to resectability. I'm going to Dr. Sudipta once again. You did mention about EUS. Now, by how much does EUS improve on assessment of resectability as compared to CT MRI? Just for the sake of our residents, if you could just give a figure before we go on to this question. Dr. Sudipta.
Yeah. So as Dr. Raju was mentioning, with the current generation of MDCTs, you can get a very good information as regards the degree of vessel involvement, whether it's more than 180 or less than 180 degrees, and whether there is a vein that can be reconstructed after surgery or at surgery. Unfortunately, at EUS, with the current generation of EUS, the degree of vessel involvement will probably not be available with the current generation. We can say there is a contact, the amount of contact, but whether there's a 180 degrees or less than 180 degrees, that will probably is unable to say.
Okay. Yeah. Now we go on to this issue of tissue acquisition. Now, radiologist tells us this is a pancreatic malignancy or Ca Pancreas, or sometimes it says mass lesion may be Ca Pancreas. Now, my question to you, Dr. Sudipta, is tissue acquisition. Is it always essential? When not, when yes? And I also would like you to address this question, and this is a bit debatable. Is percutaneous tissue acquisition a procedure of the past?
Thank you, Dr. Ramesh. The thing, as regards the surgeon is concerned, I think that their criteria and the guidelines are very clear. That when the imaging is consistent with a cancer, pancreatic cancer, and it's a resectable disease, we better not wait for a tissue acquisition and there's an associated complications related to tissue acquisitions and delay the surgery. And upfront surgery may be wise. However, there are certain situations where tissue acquisition is necessary, especially when you have an atypical mass in the imaging, which is not consistent with a pancreatic cancer, or where there is no mass, but there is just a cutoff of the pancreatic duct, and we are not unsure whether that's actually a mass producing a cutoff or whether there is a stricture of the pancreatic duct. In borderline resectable cases and patients who are planned for neoadjuvant chemotherapy, there is definitely a role for EUS-guided tissue acquisition, because before chemotherapy, it's always good to know that we are giving chemotherapy to an individual who has a cancer. And of course, there is a role in palliative cancer. Having said this, to address the next question, this is like one of our standard cases where percutaneous FNAC was done, and then which was negative, and then move ahead to EUS-guided FNAC in the endoscopy room itself. Just using a mobile camera, you can get a picture of this lesion, which is a picture of the histology and showing pancreatic ductal adenocarcinoma. It's a very quick thing. Having said this, overall, there is no difference as regards the accuracy is concerned when you compare percutaneous FNAC versus EUS-guided FNAC. And there are two studies, of course, very old, 2002 and 2013, which showed that overall there is no difference in accuracy. However, the complications are much lower when you do EUS-guided, and at EUS-guided, smaller lesions can be targeted. Having said this, we are a resource-limited country, and we have to understand where judiciously we can use it. The US has certain advantages. That is, it decreases the risk of needle track seeding, can be used to target small lesions, lower risk of complications. However, it's not widely available. It involves higher cost, and of course, it needs sedation. On the other hand, percutaneous FNACs obviate those costs with a lower cost, wider availability, no need for sedation. So in my mind, if you have a borderline resectable lesion, small lesions or atypical lesions, EUS-guided FNACs is the way to go. However, in the setting of a metastatic disease or an unresectable locally advanced lesion, either one of this is a good option.
My question to you based on this is this risk of needle track seeding real or perceived?
There are documented case reports where there has been needle track seeding and EUS-guided thing. Having said this, there was a very old paper in Gut published a few years ago which showed that there was no risk of recurrence in the patients who underwent US FNAC versus those who did not undergo US FNAC. However,
okay. Thank you. Yeah, anything that you wanted to say before I go?
There's always a concern about it, and so therefore we would try to avoid doing this.
Okay. Now, Dr. Raju, coming back to you, as I said, the crucial to decision making is resectability. So if you could just tell us what are the definitions of a resectable Ca pancreas, unresectability, and borderline resectability before we go on to the surgeon.
So one important concept is the differentiation of abutment from encasement. When we talk of angle of contact of 180 degrees, we're essentially talking of 50% of the circumference. So this is a schematic diagram showing you abutment to the SMV, where the angle of contact is less than half the circumference. Whereas this shows you angle of contact greater than 180. It involves about 80% of the circumference of the vein. And this is encasement. Another thing that we look at is the deformity of the contour of the vein, and that is also very important. If you have this kind of a teardrop deformity of the vein, that also suggests venous involvement. And this is showing with respect to the superior mesenteric artery. So a lot of what we do on imaging is assessing the contact of the tumor with the vessel. I already talked about the definitions of resectability and borderline resectability earlier. And in the interest of time, I'll just show you some examples. So this is a resectable tumor in the uncinate process of the pancreas. I hope my cursor is visible. That's the tumor.
It is not. Yeah, now it's visible.
Okay. And this is the superior mesenteric vein. This is the superior mesenteric artery. And there is almost no contact with of the tumor with the two vessels, with the two vital vessels. And this is the kind of patient that the surgeon is looking for, where the tumor is resectable upfront. A biopsy is not required. Probably, and because the findings are fairly certain in favor of a PDAC. Next slide, please. The definition of borderline resectable, unfortunately, is far more ambiguous, and it tends to differ from one center to another. And this is best done in a multidisciplinary group with your surgeon. You need to, the radiologist then helps you to decide what is the length of the vein involved and whether there is reconstructible vein above and below, but different centers follow different definitions. So essentially, we would look at coronal reformatted images along with the surgeon because this definition is a little ambiguous and tends to vary from one center to another. Next, please. Now, this is a tumor where there's a large tumor sitting in the head and neck of the pancreas, and there is a thrombus in the superior mesenteric vein, which I'm showing with my cursor. Again, the SMV is thrombosed. So if this is over a short segment and there's a vein above and below which can be reconstructed, this would again fall in the category of borderline resectable in the hands of a competent surgeon like Shailesh. Next, please. So this, on the other hand, is a patient where there is a tumor which has a contact with the SMA. Unfortunately, I can't control the video at my end. So it's showing you dilated bile ducts. There is a tumor in the uncinate process, the head of pancreas, which has a contact with the superior mesenteric artery less than 180 degrees. And this again would fall in the category of borderline resectable. Next, please. This is image again showing you the contact with the superior mesenteric artery. This is the tumor. That's the superior mesenteric artery here. And you have angle of contact, which is again less than 50% of the circumference of the aorta, again falling into the category of borderline resectable. Next, please. Unfortunately, majority of the patients that we encounter in our practice are ones who have locally advanced disease. You can see this large tumor, which is causing a teardrop deformity over a very long segment of the vein, and there was no reconstructible vein above and below, and this was an unresectable tumor. Next, please. This is another example of an locally advanced tumor where you have a tumor sitting in the body of the pancreas, which has invaded the celiac axis. It also has a broad area of contact with the aorta, and this would render the disease unresectable. Next, please. And then, of course, if you have focal lesions in the liver with a target morphology on a T2 weighted image, this is a metastatic disease, and this patient would then go in for chemotherapy. If you have a dual energy CT, you can then generate fancy images like this, do an iodine map. This is a patient who had a replaced right hepatic artery arising from the superior mesenteric artery. And so you can also tell your surgeon about variant anatomy. In this case, the replaced right hepatic had a broad area of contact with the tumor. Next, please. This is an example again of a tumor sitting in the region of the neck and body of the pancreas, which has an area of contact with the SMA, which is larger than half the circumference or more than 180 degrees, again rendering the tumor unresectable. There's a lot of awareness amongst radiologists today about perineural invasion, and we look for soft tissue traversing along the blood vessels, which then suggests that there is likely to be perineural invasion. This is a tumor located in the tail of the pancreas, which is involving the splenic artery, and that is resectable unless it goes and extends right up to the origin of the celiac axis from the aorta. Next slide, please. This is essentially showing you, if you could just click on this video, Dr. Ramesh, this will run. This is a patient who has focal lesions in the liver, bulky nodal disease. Remember, peripancreatic nodal disease is still resectable. Whatever nodes are removed as a part of the Whipple's resection, that is still considered resectable disease unless it goes to the root of the mesentery or to the para-aortic location, which then becomes a metastatic node. Next, please. If I could go to the next slide. So essentially what I want to say is that the job of the radiologist is not to just say whether the resection is going to be technically possible or not, but also go into details and try and sit with the surgeon and analyze whether an R0 resection is going to be possible or not. Next, please. Thank you.
Well, we now move on to the surgeon in our group. And Dr. Shailesh, you've heard a lot about the imaging, the role of endoscopy. I'd like to, first of all, start with a very pointed question. Would you take up a patient for surgery without a tissue diagnosis? I'll also add on one more thing to this. Would you take up a patient for surgery without an EUS? Over to you, Shailesh.
Right. So I think it's very clear that if you have a solid tumor and the solid tumor is localized and resectable and not just definitively a hypoechoic area, which is telling you clearly it's pancreatic cancer. If you are reasonably sure that you are dealing with a mass lesion, which is in the head of the pancreas, which is localized, you are justified in going ahead with a radical resection without a preoperative tissue diagnosis, notwithstanding the fact that we would still document about 6 to 15% of patients who on the final pathology may reveal something other than pancreatic ductal adenocarcinoma. I've been a part of this international study group for pancreatic surgery, and you can see that that's the conclusion. Our 26 high volume surgeons came together that in the presence of a solid mass suspicious for malignancy, consensus was reached that biopsy proof is not required before proceeding with resection. Confirmation of malignancy, however, is mandatory for patients with borderline resectable disease, because that disease is nowadays treated with neoadjuvant treatment options like good chemotherapy, and then about 70% of these patients would get a worthwhile surgical resection, which will give them a chance of long-term survival. So yes, the answer is that we would go ahead. When in doubt, we would take it out. This is our own data of 446 resections, and you will see that we turned out to be having benign diagnosis in 29 out of these 446. But out of these 29, we had 17 patients with focal chronic pancreatitis. And even for focal chronic pancreatitis, a head resection or a Whipple resection continues to be a transatlantic divide as to whether you should do pancreas preserving head coring or whether you should be doing a Whipple resection, which is what they would err on the side of doing in the Americas. This is important because in the conundrum of uncertainty, we must also make sure that we do not lose out on the chance of offering a curative resection. If you get a patient with retroperitoneal lymph nodes and with a mass, etc., which is more than 4 centimeters in size, you've already lost the battle much later, even though you might diagnose it as pancreatic cancer. So when in doubt, we would take it out is my first answer. And in this slide, you will see that we had a number of cases where we have done a variety of investigations and a combination of investigations. And even then, in about 6% or 7% of cases, we will fall short and end up offering them a major surgery. Now, there is some other areas, and both my speakers earlier on have alluded to, so they've made my job very easier. Would I go ahead with surgery for something like this? You can see obviously from the radiology that there is a dilated gallbladder, and you have a situation where you have a dilated common bile duct which is coming right down. You have a clear idea that there is going to be some block at the terminal end because you have got an excellent dilated system, but the CT has not conclusively told me that there is a mass lesion. In such a situation, I clearly need my gastroenterologist to answer the latter part of your first question, that do I need an EUS in every case? In fact, I need an EUS in very few cases which are resectable. But in this particular situation, this is resectable. A triphasic CT scan is done, vein, artery, all free, but we need to confirm that I see a mass lesion. We will, of course, discuss this perhaps later if we get the time. But for very small lesions, if it's a solid lesion, we may or may not do a biopsy via EUS, depending on what we are thinking radiologically and clinically for a patient. So sometimes my endosonographist would just do an endosonography and tell me, this is no stone, this is no worrisome stricture or a benign stricture. You clearly have a solid mass lesion, and do you need a biopsy? And I would say sometimes yes, and many a times I would say no. As long as it's a lesion, this is good enough for me to take the patient to the operation table to offer radical curative surgery. We've heard such excellent update from Dr. Raju Sharma, who's an expert, that he's made our surgeon's job easy. But in every center, you don't have a Raju Sharma. So I think I would also urge the younger members especially that when you evaluate your patients, do not look only at the radiology printed report. Every clinician interested in management of pancreatic cancer, he or she must be able to study the CT scans on their own in great detail. So this is what we looked at, that we would prefer MDCT, triphasic, as the first imaging modality. In the era where you have got confusion about chronic pancreatitis and IPMN, we would also add an MR or an MRCP as a complementary test, not as a competitive test. Otherwise, I'm happy with only one CT scan. EUS Sudipta has very nicely highlighted, but we would recommend it for assessing lesions not clearly detected but suspected in borderline resectable, as I told you, and in some cases to assess vascular involvement. But as our experience in surgery has grown, we have realized that we actually don't depend on an EUS for vascular involvement. I depend on a high quality triphasic CT scan, and I get all the information that I need.
Thank you very much, Shailesh. Now we go on to surgery and beyond. I think I'll stay with you, Dr. Shailesh, and my first question to you would be, I had mentioned in the beginning, if at all you're looking for a curative solution, it is surgery. The role of surgery in Ca Pancreas, what are the major issues in resection that you would like the gastroenterologists to be mindful of? And
Yes.
whether there will be any difference between your approach to borderline resectable cancer or locally advanced cancer.
Right. So again, my job has been made easy and it's flowing very well the way you have designed this session. Again, for a surgeon, I want both my radiologists and gastroenterologists to be aware that this is the way I think. Beyond NCCN and ISGPS, my practical working table is this particular one. That the red box highlights to you what I, as a surgeon, am clearly able to see as resectable disease. But it includes two distinct categories. You have the major vasculature like the veins and the arteries, and resectable is easy. There is no vein, no artery involvement. Patient is fit for surgery. Best thing is to do a radical R0 curative resection and give the best possible chance of long-term cure. Borderline resectable, superior mesenteric artery, celiac axis should be less than 180 degrees affected. If the vein is more than 180 degrees affected, it is still resectable disease in experienced hands as long as the disease does not progress under neoadjuvant chemotherapy. And the locally advanced and unresectable disease is when there is encasement around the artery in the retroperitoneum, or there is no encasement, but the length of the vein involved is such that you don't have a superior mesenteric vein inferiorly that is available for the surgeons to join back and send the blood supply back to the liver. So these are my broad concepts when I look at what is resectable versus borderline resectable versus locally advanced. Point number two, in borderline resectable, it's not only about good radiology by Dr. Raju Sharma or EUS by Dr. Sudipta. I think it's important that you first look at your patient. And that's where the ABC classification is important. And I would urge the younger members to study this very well. That B is biological definition of what is borderline resectable. A is, of course, the anatomical definition, which we all discussed in great detail so far. In biology, you have CA 19.9, but I would add a caveat to that, that a high CA 19.9 in the absence of obstructive jaundice is important. If you have a high CA 19.9 in the presence of obstructive jaundice, I would rather have the obstructive jaundice drained and reassess what is the true baseline CA 19.9, which would contribute both as a baseline marker for monitoring response to treatment or influence the surgeon's decision to do a preoperative laparoscopy to rule out a high chance of metastatic disease, especially if the CA 19.9 is 300, 400, etc. The other part is that you see number of lymph nodes. The minute you see lymph nodes, even in resectable disease, in the vast majority of times, you are dealing with grade 2 or stage 3 pancreatic cancer, even if they have got a good surgical resection. And then, of course, it is the conditional definition as well. So I might have a favorable A and I might have a favorable B, but I might have an unfavorable C. And then the surgeon needs to decide that am I trying to play God, or should I just stop and look at palliative options, giving good quality of life, give chemotherapy, radiotherapy, and not subject them to a high risk surgery. That's one part. Looking at the other part through a surgical perspective, again, where the gastroenterologist would help us in a multidisciplinary treatment board, is that if I have abutment in scenario A, and even in scenario B, as I get a more and more confident surgeon, even if there is partial encasement of the vein, I get a great surgical plane which is there between the superior mesenteric artery and superior mesenteric vein. So I completely safeguard both the arteries in both the scenarios and get the tumor out. Will make me a very happy surgeon. And in this situation, if I'm a competent surgeon, even with complete encasement, I would still be able to take it out because of superior mesenteric artery first technique, which is a surgical approach, which I'm not going to discuss now in detail. But while doing this, it's good to look back what has been published more than 13 years ago by a very well-known vascular surgeon from Japan, by Nakao, that if you start getting collateral formation, if you have complete encasement, or you have a severe venous deformity, these group of patients don't do very well in the long run, even if you do a great surgical resection in pancreas cancer. And it is this group where the surgeons actually need the gastroenterologists, because I need a tissue diagnosis from them, because I want to confirm suspected diagnosis of pancreatic cancer and then get in my medical oncologist to treat what is essentially a systemic cancer and then consider surgery rather than a big technical exercise. There is another area which is coming back a little bit to the pre-operative phase. When you ask me what can a gastroenterologist do and what surgeons want gastroenterologists to know, of course, we can go on and have a debate on this subject for an hour. But just now, the brief for me to share with you is that we would have problems if the endoscopic procedure has been a complicated one. We would have problems if there is associated pancreatitis. And these problems is not just a surgical problem. This has got a direct impact on the patient's post-operative recovery and outcome. This is an old study from our team of 144 resections. And if it was a smooth, well-done ERCP with a stent, there was no problems. But if there was a complicated ERCP, there were big problems. Point number one. Point number two, if the patient needs real good optimization, we are not the ones in a hurry to get a stent on a Monday and attempt an operation on a Wednesday or the following Monday. The stenting has been, in my opinion, for three most important reasons. One is that the patient is nutritionally not good. Two is patient has got cholangitis and or coagulopathy. That's no rocket science. They all must get stent. Three, if they are going to get neoadjuvant treatment, which is going to go on for 2 or 3 months, I want them to get a expandable metal stent. I don't want them to get a plastic stent. There is enough data. I don't want the chemotherapy to get interrupted with cholangitis and other problems. I want good, consistent, safe drainage of jaundice, bilirubin of less than 3, and then chemotherapy is possible. So I think that's important for my gastroenterologist to know when I want a plastic and when I want a metal stent. And then I would wait for 3 to 6 weeks and then I would go ahead with surgery. Since the disclaimer was no neuroendocrine and no cystic tumors, we can discard this slide and go ahead as to when I need, and even this one can be discarded and we can reach,
So what are the prognosis after a good, generally there is an air of, a defeatist attitude or, desperation as far as Ca Pancreas is concerned.
Yeah.
So what is the prognosis? We know that you are a large volume center.
Yeah.
And what messages emerge from these data?
Yeah. So what I can share with you is that we have got very good perioperative outcomes on par with the best in the world. You can see that we have developed and we continue to develop into a very high volume center for Whipple resections across the country. And we are confident of our perioperative outcomes. But speaking of long-term outcomes, you clearly have to differentiate between pancreatic cancer and periampullary cancer. With periampullary cancers, we clearly have a 5-year survival, which is now going up to 40 to 50%, even with node positive disease for stage 1, stage 2, stage 3 taken together. But when it comes to pancreatic head cancer, I'll bring your attention to the landmark study by John Cameron from Johns Hopkins, where if the pancreatic cancer was node negative, you would have more than 40% patients alive at the end of 5 years. So is it a bad cancer? It is a bad cancer. And for all stages together, if you do a radical surgery, are you going to have a situation where 20% people will live and the remaining 80 will die within the next 5 years for pancreatic ductal adenocarcinoma? Yes, the answer is true. But if you get node negative, the figure improves. And more importantly, with chemotherapy, adjuvant chemotherapy, we now have reached a situation where the number of patients who are living for up to 5 years has now gone up to somewhere between 30 to 40%, because if they get good safe surgery and then they get good chemotherapy and it is finished in a particular span of time, then you will have about 30 to 40% patients who are alive. The same group of patients 2 decades ago, we were looking at data of 15 to 20% 5-year survival. This is borne out by studies by the CONCO study, by the SPAC group, right from the turn of the century to the most latest SPAC 5, which clearly shows that chemotherapy has made progress on the background of good quality safe surgery. This is our own data from Tata Memorial. And now we've got a series of more than 1,600 Whipple resections. And it's obvious that whatever is the world experience, we are able to have about 2-year survival of 78% of patients. Of course, it tapers down to 20% for pancreatic head cancer, but it's about 40% for periampullary tumors, even if they are node positive after a Whipple resection. We do get 57% patients who are R1 resection on pathology. It's more because of specialized pathology and not due to poor surgery, that you will still get about, for pancreatic head cancer, close to 60% patients who are R1. But even that group of patients with adjuvant chemotherapy can expect a better, meaningful length of life than just a decade ago.
That's a large volume of data.
Yeah. And
data, and the box that in the right corner, I think is important for us all to understand as medical gastroenterologists, that we are now looking at probably better outcomes as far as surgery is concerned. And this is something that all of us must realize as a medical gastroenterologist fraternity. Thank you very much, Dr. Shailesh.
Thank you.
Could you just do me a favor by deleting those marks that on the screen? Is it possible from your side?
Yeah, I don't know. How do I delete them? I'm struggling now.
I know. Raju may help. Anyway, we'll just go on with the discussion. Before
I also want to delete them. What can I do to delete them? I could annotate them and then...
Clear.
Clear?
Yeah, press clear.
Now, Sudipta, we did have...
Shailesh, just click on view options.
Okay, thank you. It's there.
Yeah. Now, Sudipta, before I go on to our oncology colleague who's been waiting in the wings, and as we know that oncology has got a very, very important role to play in this different or emerging change in outcome, I just like you to address this particular issue once again about routine pre-op biliary drainage. Now, is it routine, number one? Number two is, if so, what is your preferred mode of drainage, when and why?
So I'll just take you back to what Dr. Shailesh was also alluding to in his presentation, that basically there is a very limited role for biliary drainage. But if you look at the data which has been there in literature, very old data from 1985 also showed, this is probably the only randomized trial which showed that fewer surgical complications happened when they did a PTBT. However, when they included the PTBT complications, this advantage of also decreased. Overall, most of the studies have shown that their complication rates are definitely higher when we do a biliary intervention. But however, there is no difference in the overall survival, length of hospital stay, or the morbidity of the morbidity. However, the complications do go up. This is, again, a meta-analysis of the 3 randomized control trials and 22 retrospective studies. And what is more important to note here is that the bilirubin level that was recruited for the randomized control trials, including the DROP trial, which is a large randomized control trial, was less than 15 milligrams per deciliter. So patients who are having bilirubins less than 15 milligrams per deciliter, when we do ERCP versus surgery, ERCP increases post-ERCP overall complication rates, increases the risk of wound infection, and there is no difference in the early perioperative mortality, intra-abdominal abscesses, or pancreatic fistula formation. What it goes on to show that pre-op ERCP in patients who have bilirubins less than 15 milligrams per deciliter is probably not of great value and only adds to complications and delaying surgery. So when should we, if you ask, then the question answers would be if there is underlying cholangitis in an individual. If the person is a candidate for neoadjuvant chemotherapy and the patient has intractable pruritus and there is a delay in surgery, anticipated delay in surgery for more than 2 weeks. And in patients, of course, this number is controversial, can be variable between different things. But for us, if the bilirubin is more than 15 milligrams per deciliter, we have no evidence to justify not doing stenting. And so therefore, we can say that in patients with bilirubin more than 15 milligrams per deciliter, we should go ahead and do a biliary stenting.
And when you put in a stent, it will be a metal stent or a plastic stent?
When the patient is a candidate for a surgery as a borderline resectable planned for a neoadjuvant chemotherapy, we usually prefer a plastic stent. The goal here is to put a plastic stent below the cystic duct origin and just to attain biliary drainage. We do not put a metal stent because of the complications related to surgery. Everyone has different skill sets, and so considering keeping that in mind, we stick to putting in only plastic stents.
But our surgeon, I presume, is happier with a metal stent being put in because he feels that probably the quality of palliation or whatever, say, the improvement is much better with metal stent. Isn't it, Dr. Shailesh?
Yes, I was just raising my hand up to make a comment that I understand that cost is a major concern and cost will drive treatment and should drive treatment because this is practical reality. But in an ideal world, if I'm discussing science where there is a patient who has an eminent 70% chance of getting a good resection after chemotherapy, then I don't want as it is, chemotherapy causes complications with immunity and other challenges. So we don't want a stent getting blocked. And if I'm to understand the data coming from gastroenterologists and endoscopists, a plastic stent would have a 30% chance of blocking, while a SEMS would have a less than 5% chance of blocking. Statement number one. And statement number two, I have no problems dealing with any kind of stent. Even a metal stent can be extracted out during surgery, and even a plastic stent can be extracted. So I think it should be a decision looking at socioeconomic status, intent of treatment, performance status of the patient, and then do what is best for the patient.
Thank you very much, Shailesh. We now go on to the oncologist, and I'll request Dr. Akash Jha to unmute himself. 2 questions to you in succession. First is, what is the role and mode of neoadjuvant therapy for Ca pancreas? We all understand that borderline resectable, there is a role for neoadjuvant therapy. What is your advice as far as neoadjuvant therapy is concerned?
Thank you, sir.
So before I start, I want to share few things that is different in Ca pancreas in comparison to other solid tumors for our colleagues, junior colleagues. First thing is in pancreas, even if after so many years of research and improvements, R0 is not the main thing that we want to achieve. There are many trials, they're all larger trials. They have accepted R1. It's not because that we want to do that, it's because we are getting that. And if the patient is going for an upfront surgery, R1 is an acceptable. Around 50% of all the cases in all major trials of adjuvant chemotherapy, R1 has been accepted in those cases, and chemotherapy does make a difference. Although the amount of increase in survival is not as good as in R0. So that is one thing that we want to tell. Besides, coming to my own topic, this neoadjuvant chemotherapy, there are two things that is very important. Raju sir has already mentioned in MDT you have to decide, but we at our center are more comfortable with surgeons are comfortable with. If they think, if their surgeons are okay, that they most of the time they take the upper hand and decide it is borderline resectable, because it depends on the expertise that we have at our center or at any center. Because at times the different institutions worldwide have adopted different criteria for borderline resectable. So that is one thing. Besides, for neoadjuvant chemotherapy part, we have to understand that there is no high level trial, robust data that only answers neoadjuvant therapy. So all the data that has come up from the adjuvant setting or metastatic setting. So the drugs that have been, or the combinations that have been used in metastatic setting, that have been used in neoadjuvant setting. So that is, these are the chemo drugs that are the 5-6 the whole gamut is of these 5-6 drugs. It is 5-FU capecitabine, this is gemcitabine, nab-paclitaxel, platins, and irinotecan. The whole idea is the combination or a single agent. So that is one thing that we need to know, that if the patient has to be fit enough for neoadjuvant chemotherapy, because unless you give a proper combination chemotherapy like FOLFIRINOX, the patient will not convert into completely resectable status. So first thing is biology of the, performance status of the patient, the age and the ability to tolerate these regimens. Definitely after the advent of FOLFIRINOX, it has every other combination. This is a combination of 5-FU, irinotecan, and oxaliplatin with leucovorin. Besides gemcitabine and nab-paclitaxel, is another regimen that has been effective in poor PS patients, mostly PS2, 0 to 2, and FOLFIRINOX in 0 to 1. And if the patient is a BRCA or germline carrier, there is a PALB2 mutation carriers, platins do act well in these cases. So maybe FOLFIRINOX or gemcitabine cisplatin combination would act. Besides, the role of RT is still blurred in this setting. There are multiple large trials are ongoing who are looking at that subsequent first chemotherapy followed by chemoradiation and then the effect. But till now, the data is very blurred. We are not very sure. Not many good data is there. So RT is dark right now. Next slide. This is a classical FOLFIRINOX regimen just for new junior colleagues. These are the recombination. This is 2 weekly. You don't need to remember the doses, but across 2 weekly FOLFIRINOX. Generally in neoadjuvant setting, we go for 2 to 3 cycles before surgery. One thing that I want to add right now that is very important. After neoadjuvant chemotherapy, we generally go for a repeat imaging and CA19.9 and symptom assessment. There are 3 important things that we need to know. So after either gemcitabine, nab-paclitaxel, or FOLFIRINOX, if you feel that there is a significant clinical improvement, there is a significant decrease in CA19.9, but on imaging, if you feel that the tumor remains the same, you should not worry at that time. You should not deem it as unresectable at that time. You should go for a diagnostic laparoscopy and see. Most of the in retrospective series, they have shown that after neoadjuvant chemotherapy, up to 50% cases can can become resectable, although not visible on repeat CT scan or repeat imaging. So post-neoadjuvant chemotherapy, you should ask your surgeon or you request them to go for a diagnostic laparoscopy and see for resectability, because imaging is not a good modality at that time. Or I have already mentioned role of radiotherapy is very debatable. Let's see. Okay.
Okay. I'll stay with you, Akash. We were talking about neoadjuvant. Now, I want to ask you about the role of chemotherapy and radiotherapy in unresectable cancer pancreas. You're talking about neoadjuvant, but is the outcome really bad? Because many of us, when we are faced with this situation, we say, okay, gone, nothing else to be done. Is it really that bad?
Sir, right now in present scenario, as Sir has already mentioned, the outcome has improved significantly. Right now in adjuvant setting, the FOLFIRINOX that has just recently published few months back, that shows that the overall survival has ranged up to 54 months in comparison to only single agent gemcitabine. So definitely the survival has improved significantly, and that trial also included around 40-50% of R1 resections. So we are talking about the whole upfront resectable thing. Even if there is R1, it is okay for now, unless we get something bigger. These are the slides that I have taken from for adjuvant setting. If the patient is upfront resected, either R1 or R0, as you can see the previous slide, this is the ASPECT trial. This is the evolution of ASPECT trial. There is European group that had compared multiple up to ASPECT 4, and this is, as you can see, the curve has consistently improving over the years. So we are doing something, we are achieving something. So it's improving significantly. Last ASPECT 4 was GemCap. This is the same thing that we are seeing. The median overall survival has changed after various trials. This is the past trials that we can see. Next slide. This is the game changer. So FOLFIRINOX, that has been effective in metastatic setting, the most active regimen we have. Right now, the survival has ranged up to 54 months, and you can see the 3-year overall survival is around 63% in if the patient is fit enough to tolerate all forms of FOLFIRINOX in that. So we are improving a lot in that sense. Now for the unresectable metastatic setting, the outcome is bad. Definitely it is bad. But here again, the chemotherapy has made some changes. The most effective is FOLFIRINOX. That is the combination of 3 major drugs. Most importantly, the problem with FOLFIRINOX is high toxicity. So the performance status, the patient acceptable is 0 to 1. You cannot go above 1. And it has led to a significant improvement in survival. I can see 11.1 months versus 6.8 months. Next slide. The second most active drug combination is nab-paclitaxel and gemcitabine. You can see the survival has increased from 8.5 to 6.7 months. It is almost 2 months survival benefit, but we have to remember these are poor risk patients, poor performance status, PS2. So it is still we can give in even those patients who are all the more poor risk patients, we can give even single agent gemcitabine also. Next slide.
Thank you very much. Now, I think we've run out of time. It's 10 past 1, and I had promised that I will wind up the panel, but I know that I have not been able to tackle that issue of patients with carcinoma of the body and tail. So I'd like to, Dr. Shailesh, to just tell us briefly, without the help of any visuals, what would be your approach to a patient who's got a mass in the body of the pancreas or the tail of the pancreas, before we go on to the concluding slides?
Yeah, so I think you can have the same approach that you have for a pancreatic head cancer. Pancreatic cancer is a bad cancer, is accepted whether you're dealing with body, head, or neck or tail. And the clear answer is that if it is resectable disease, resect it with a radical modular pancreaticosplenectomy with an adequate and a complete lymphadenectomy, and you will still get the same figures for 5-year survival as you get with pancreatic head cancer. The problem with pancreatic body tumors is that many of them are in close contact with the celiac axis, and a number of them would be considered to be unresectable because of the fact that there is arterial involvement. But that is not always the case thanks to better chemotherapy that we are getting. And if you can show me just one of my slides of the intraoperative picture and a CT scan, I can wind up in less than a minute. That's the one. Yeah. So here, just the one before. So this, just to show you, is the hepatic artery, the splenic artery, a tumor going right down, pancreatic body cancer, and unresectable, locally advanced, but good chemotherapy, good FOLFIRINOX, good response to treatment, and then radiology telling us that the gastroduodenal was also supplying the liver well. Next slide. What we have done here is that we have divided the pancreatic neck to the right of the portal vein. We've resected the celiac axis. That's the crus of the diaphragm, the superior mesenteric arteries here, the divided common hepatic arteries here, but the gastroduodenal artery supplied the blood to the liver. We were prepared to replace a hepatic artery here. So a body tumor which responded well to chemotherapy with good performance status, you are able to do a celiac axis resection. So formerly something considered as unresectable is clearly resectable. And the last bit, pancreatic tail tumors, we have documented our work with ramps, and you will get a 3-year overall survival of 56% and a disease-free survival of about 38%. That's all that I would like to say.
Thank you very much. Thank you very much, Dr. Styler. So we come to the concluding aspect of this webinar, where we just deal with a few algorithms and few messages that have emerged from our presentation. The first and very important message that has emerged is, if you are going for an imaging good contrast enhanced CT done with a pancreatic protocol is extremely important in assessing and for a decision regarding resectability. And resectability is basically a radiological diagnosis, and which will be given to us by the radiologists. And this would probably be the algorithm for diagnosis. I'm sure there is no difference of opinion as far as this is concerned. Starts with the clinical manifestations, the dynamic CT done with the pancreatic protocol, the role of ERCP dwindling absolutely, the role of cytological and histological diagnosis we have already diagnosed. And once we have the stage, then of course we need to classify them into resectable or initially unresectable or borderline resectable, and then tailor our modality of treatment appropriately. All these things we have actually discussed in detail, the role of neoadjuvant therapy and the algorithm for oncotherapy. In conclusions, I would like to say, pancreatic ductal adenocarcinoma is best managed as an MDT, multidisciplinary team, and Dr. Raju put it right up front. It is important that there should be an open discussion between the radiologist, the surgeon, and the gastroenterologist about the best way forward, and also the oncologist. Advances in imaging have led to accurate diagnosis and staging. When needed, endoscopist provides tissue diagnosis and further staging through US. Surgical resection, even now, is the only chance of cure. Improved surgical techniques with respect to venous reconstruction has resulted in increased resectability. Newer chemotherapy protocols with or without radiation have resulted in better survival. The strategy, however, remains palliative. Neoadjuvant therapy in the preoperative setting is very promising. Effective pain management, and that's something that we could not discuss, is very crucial, and that's done both by the gastroenterologist as well as the pain and palliative person or the oncologist. Despite all this, pancreatic ductal adenocarcinoma remains a silent killer, and we await a biomarker for early detection, which is desperately needed. Thank you very much to all the panelists. It was wonderful having been associated with you. All of you have been great. All of you have been very, very clear as far as your messages are concerned, very crisp. Thank you very much, ISG, for having given us this opportunity. And with this, it's over to Dr. Vivek Saraswat to conduct the Q&A session. And as promised, the time 1:15.
Thank you, Dr.
Thank you very much, GN. Could you please stop sharing your screen now so that I think the panel can...
I will do that.
Yeah. I think GN has led this whole discussion in an exemplary manner. All the focus and the clarity comes. If you ask a clear question, you get a nice and clear answer. Thank you, GN. So I think there have been a few questions, and some of them probably have been covered, but there is no harm reiterating these very important messages. So Dr. Anand Gupta from Jaipur wants to know, I think repeatedly, we have talked about a pancreatic protocol CT and versus a triple phase CT. So especially when you're trying to look for secondaries in the liver and also assess the pancreatic SOL, Professor Raju Sharma, what do you suggest? There should be a triple phase or a pancreatic protocol, or how should the clinician go about it? So, sorry, you are muted. If you could unmute, please.
I think in my view, a pancreatic protocol suffices. We do a pancreatic phase at 45 seconds and a portal venous phase, which is good for liver metastases, at 70 seconds from the beginning of injection. All the information about the arteries is available on the pancreatic phase as well. So there's really no major difference between a triple phase versus a two-phase CT, which is taken in the pancreatic phase and the portal venous phase. A lot of literature supports this, and this is what we follow in our institute.
So a pancreatic protocol CT generally will suffice. And obviously, if there are indeterminate areas and other questions to be answered, you've already covered that in your presentation. Thank you, Dr. Raju Sharma. Regarding CA99, I think the non-jaundiced and jaundiced patients, its value was mentioned. The question was, which patients should every patient have it, and what should be the timing before or after drainage, or before taking the patient for surgery? Maybe a quick answer to that, one of you.
Yeah, so I would just say that just before starting of treatment, whether it's surgery or chemotherapy, a baseline serum CA19-9, hopefully after resolution of jaundice, would be reasonably specific and sensitive, though it's essentially a non-specific and a non-sensitive marker, but it can help both the surgeons and the medical oncologists to monitor response to treatment in case it is elevated, because it's not elevated in all patients.
Right. And it helps you in follow-up after resection also, Dr.
Oh, yes, because if it is high in the beginning and then we've done chemotherapy, surgery, chemotherapy, and there is a nice decline, you can clearly follow up your patients every 4 monthly, SOS with additional scans, and even give them second line of chemotherapy, etc., because it can help you in detecting a relapse. And so it's good to have a baseline before you start treatment.
Right. Dr. Sudipto, I think there are a few questions regarding stenting. So Dr. Bilal Mohammed from Cochin and Dr. Avinash Tiwari from Srinagar and a couple of others wanted to know, you were emphasizing plastic stents, but I think repeatedly, there have been mentions about if people are able to afford, which SEMS, covered or bare, would be preferable in case a metal stent is to be used?
So we are talking of stenting in two scenarios, sir. One is when we are doing stenting for the palliative intent and stenting for a bridging intent for the person.
Yes, these questions were for the pre-operative drainage.
First instance, when you're doing it for the pre-operative stenting, for our center, our surgeons prefer that we put a plastic stent, considering that there are two reasons. One, basically, some surgeons obviously have a difficulty. It depends on the, as I was saying, expertise. Some people have difficulty doing a surgery when there's already a metal stent in place and there's a reaction around the bile duct, and the difficulty associated with the surgery involved. And second most important thing is that if the surgery is planned within a period, within a month, then obviously it obviates the need for a re-intervention, because plastic stents, as we know, plastic stents can last for at least for 2 months. Or 2 plastic stents can take care of the job. When you're talking for palliative intent, then obviously it's an uncovered metal stent that you're talking about. And if you're talking about preoperative, if you plan to put a metal stent, then should be a fully covered metal stent. And for any circumstances in a preoperative setting, we would try to put the stent below the cystic duct origin.
Right. And I think in the setting when you are headed for new adjuvant therapy and biliary drainage may be required for a longer period of time, would be another case for a metal stent?
Yeah, that may be worthwhile considering a metal stent at that point, but that should be in consultation with the surgical unit concerned.
Right. Thank you. Dr. Bhavesh from Lucknow and Dr. Avinash Tiwari from Srinagar have a question on neoadjuvant chemotherapy. Which patients should be offered? How do you choose patients for neoadjuvant? And should every resectable patient or only selected patients be offered neoadjuvant therapy? Dr. Jha?
So for neoadjuvant chemotherapy, the most important thing is the discussion in MDT. If the surgeons are completely comfortable and we classify after discussion with a radiologist and surgeons that it is borderline resectable and the things are clear, and then we decide for neoadjuvant chemotherapy. And the regimens, the intensity of that is also dependent on the general condition of the patient. If the patient is young, the general condition is really good, because giving half-hearted chemotherapy never helps. So you give combination good chemotherapies like FOLFIRINOX and some other chemotherapy that has a high efficacy, but then that it has high side effects also. So the patient has to be young, fit individuals. The case has to be on imaging and on surgical assessment. It is borderline resectable. Then only we choose that we can go for a neoadjuvant setting.
Thank you. So basically what you're saying, there are two things that have to be seen. Number one, that it is a borderline resectable as discussed between the surgeon and the radiologist for complete evaluation. And two, the patient has to be fit to tolerate a full dose aggressive neoadjuvant therapy course. Right.
Very true.
Well, I think maybe Sudipto, you might want to take this. Dr. Tayumanavan from Chennai wants to know what is the protocol for screening for cancer pancreas in chronic calcific pancreatitis, in idiopathic pancreatitis, and how do we go about it? A very naughty question, but once you admit that there is an increased risk, we have to suggest ways to tackle it.
So the problem, particularly, this is a very relevant question, sir, because this is the scenario that we face in India. Patients with early onset idiopathic chronic pancreatitis go on for a long time, and we do not have a particular screening protocol in place, primarily because of two reasons. There is no very well-defined pre-neoplastic lesions that we can identify with the current generation of imaging technologies, are not a very well-validated tumor markers that are available in practice. Having said this, a number of studies have evaluated both CA19-9 as a tumor marker for chronic pancreatic cancer in the setting of chronic pancreatitis. In fact, one study from Chennai, in fact, had looked at it and showed that if we have a pancreatic head mass where the tumor levels or CA19-9 levels are more than 127, in the presence of a elevated bilirubin or ductal diameter, there's a high probability that the person might be harboring a neoplasm. Other studies also from India have looked at different levels of CA19-9 from 300 to 127, one from 80. However, all these studies have not been done in a systematic manner. Having said this, there's a new monoclonal antibody which has now come in vogue. This is the PAM4. And this monoclonal antibody has been shown to be elevated in patients with pancreatic cancer and not in patients with chronic pancreatitis. So maybe the future lies in using a combination of CA19-9 along with PAM4 to identify neoplastic or pre-neoplastic lesions in the setting of chronic pancreatitis. As regards imaging is concerned, we in our center, we keep on doing ultrasounds at 6 monthly thing, but we know the sensitivity of ultrasound to pick up early lesions is very poor. Doing an endoscopic ultrasound every year is kind of difficult and not feasible. So probably we are looking at only using CA19-9 and future lies in PAM4.
Shailesh wanted to make a point. Shailesh.
The only comment that I would like to make is, yes, it's a gray zone, and we know that it's a field defect in chronic pancreatitis. Suresh Chari showed us long time ago about the high risk of pancreatic cancer in long-standing chronic pancreatitis. I've done some work on this before, comparing tropical, idiopathic, and alcoholic chronic pancreatitis and their progress. The only thing which concerns me more in the clinic, even now, in a place like Tata, which is obviously a referral place, is a number of patients who have had a head mass in chronic pancreatitis. They've been asymptomatic, and then they have been treated conservatively because pain has not been there. And then a number of these patients have had pancreatic cancer, many a times a florid situation over which we have had no control. So I think whenever there is a patient of chronic pancreatitis showing signs of developing complications, i.e., obstruction to the bile duct, the ductal morphology, etc., I would feel that it's important to integrate a surgeon at an early stage in a multidisciplinary clinic, so that we will try and get some patients who can be operated in time, rather than be missing out on long-standing chronic pancreatitis who are dying of pancreatic cancer in the head especially.
Right. Thank you very much. I think and does Professor Raju Sharma or maybe Jain, you would like to have any other comments on this? Because
I would like to ask Dr. Raju Sharma. In fact, with the present technology available, a good pancreatic protocol CT gives us a very good idea. So a good pancreatic protocol CT plus human intelligence should sort out the problem in virtually 95-96% of cases. Do you see any role for artificial intelligence in the near future, as far as this problem is concerned?
So there are a lot of publications that have come in the last 1 year on AI in pancreatic cancer. And people are working on all kinds of things. They're working on texture analysis. There's a whole new emerging field of radiomics, which now looks at images as quantitative data rather than just qualitative image for the analysis of the radiologist. Because there are many things which computer algorithms can pick up in the image which the radiologist cannot see. So there are umpteen number of studies going on all across the world which are looking at texture analysis of pancreatic cancers to predict prognosis, to pick up association with genetic mutations in the KRAS gene or in the BRCA1 gene, and also trying to predict response to chemotherapy. So these are interesting times, and hopefully in a year or two, we'll have data to discuss.
It's 1:30. I think we've reached the time limit. So it's back to you, Dr. Vivek, for the final words. And
well, I must, I think, Jain has already said it, and I cannot say in very many different or better words that this has been an outstanding session, and each one of the panelists has provided very clear and lucid insights into the areas of therapy or diagnostics that they were requested to do. And I think Dr. Ramesh has structured this whole panel discussion very well by articulating very clear and distinct questions. So in about 90 minutes, we have managed to cover a vast area, given you and given all our audience an insight into what is going on and where there may be new developments in the near future. Although still pancreatic cancer remains one of the most challenging conditions for the clinician and the entire multimodality team to manage. So I'd like to thank each one of you very sincerely for all the hard work put in and for putting this panel discussion together.
Thank you.
Now, I think before we close, a quick couple of housekeeping announcements, as well as to tell you that next Sunday, we'll be having a panel discussion on the multimodality management of carcinoma of the esophagus. And again, we have a very distinguished panel led by Dr. Bhaskar Nandi, who will be the moderator. Dr. Amit Mayadev will talk to us about the role of the therapeutic endoscopist. Dr. Amit Agarwal, medical oncology at the B.L. Kapoor Hospital, Delhi, will talk about the role of the oncologist, while Dr. B.K. Mohanty, who's the director of the KIMS Cancer Center in Bhubaneswar, Orissa, will talk to us about radiotherapy. We will also have Dr. Saugata Sen and Dr. C.S. Pramesh for imaging and surgical oncology from the Tata Medical Center as well as Tata Medical Hospital. So, another exciting panel discussion to look forward to next Sunday. Now, as you all know, the ISG annual conference is coming up in November, and abstracts, we are happy to announce that a very large number, about 390, almost 400 abstracts have been received this year, which is in excess of what we actually used to get in non-lockdown years. So in a way, I think lockdown has helped more people to get their work together and to submit it for ISG. So we look forward to a very a good meeting in Pune in December. Also, the ISG elections have been announced, and all of those of you who are interested are requested to look at the announcement and send in your papers to Dr. Rakesh Kochar at PGI Chandigarh. So with these few announcements, I'd also like to thank the sponsors who have helped us to bring this session, Lupin Pharmaceuticals, as well as our facilitators in the background, whom you don't see, you don't hear, but they make this happen. Mr. Dinesh, who's been providing technical assistance for this transmission, and Yogita from the ISG Secretariat, who does all the coordination work. Thank you all very much. Thank you once again to all the panelists, and especially to you, GN. And with this, I'd like to say bye-bye till the next Sunday, when hopefully we'll all get to participate in the next panel discussion. Thank you very much.
Bye-bye.
Bye. Thank you very much. Thank you very much.
Welcome. Okay.